To this webinar on boosting gut health and building a health claim. It's hosted by NIZO Food Research in the Netherlands. This webinar will take approximately 60 minutes and it will include a presentation by my colleague Alwine Kardinaal. She will start focusing on EFSA's guidance and learnings, and a presentation by me, Sandra ten Bruggekate, focusing on research tools to build the evidence for a health claim. During this webinar, there is the possibility to ask questions in the question box. This is, I think, right hand on your screen. We will answer all the questions either during this webinar or afterwards by email. We hope you will enjoy this webinar, have fun, and I'll now give the floor to Alwine Kardinaal.
Welcome to all of you. Our presentation of today is about boosting gut health and building a health claim. My name is Alwine Kardinaal and I'm a Project Manager Health at NIZO Food Research. Now, before starting with a closer look at health claims, just a one-slide introduction of NIZO Food Research. At NIZO, we offer services in different areas as a private contract research company for the food industry, and all the areas are related to the development of better foods. And one of these areas is the health research, in which we have over 25 years of experience by now. Now, what's clear from market research is that gut health and immune function are important to consumers. So if your product has a beneficial effect on gut health, you want to share this with the consumer. Now, we are all aware of the EU regulation on nutrition and health claims, which says that communication on health benefits should be authorized and based on scientific evidence. Now, in this webinar, we will address the following topics. What can we learn from EFSA practice in recent years about gut health claims? And what are effective models in humans that can be applied to substantiate health claims? And I will guide you through the first part, and Sandra will take over halfway to present the research models. Now, health claims should be supported by scientific evidence, and then the EFSA panel evaluates the evidence that you supply to them. The panel starts always by asking three questions. First, they want to know if the food or constituent is sufficiently defined and characterized. The second, it is important whether the claimed effect is sufficiently defined and if it is a beneficial physiological effect. And lastly, have you presented pertinent human studies to substantiate the claim? And if any of these questions is answered negatively, the conclusion of the panel will be that a cause and effect relationship has not been established. On the other hand, if all three questions are answered positively, the NDA panel will look at the quality and the results of all the individual studies and weigh the overall evidence. Now, in the area of gut health, many ingredients, and especially the probiotics, were deemed to be not sufficiently characterized by the panel. And likewise, in many cases, the claimed effect was not considered a health benefit. And think, for example, of changes in the number of bifidobacteria of lactobacilli. Now, both these issues explain why quite many health claims in the gut health area have been rejected, and certainly in the earlier stages of the EFSA evaluation process. Now, some health claims related to bowel function have been approved, but other gut health benefits seem quite a bit more difficult to demonstrate. It is often illustrative to discuss the reasons of failed applications rather than the successful ones, because we can all learn from that. Now, if you happen to have had a gut health claim rejected, you are in very good company. Health claim applications of major brands had similar problems, and some of them are mentioned in this slide. I suggest to have a closer look at the last two on this slide, the Actimel and the LGG claims, which are related to defense against pathogens. Now, LGG is a probiotic that has been evaluated in a large number of human studies with various endpoints. And a claim application was submitted for defense against pathogens. What EFSA did is that they looked critically at the design and the quality of all studies, and 7 of these studies were included in the panel's evaluation. Now, gastrointestinal infections are considered an appropriate outcome measure if at least the infectious nature of the disease can be assessed with a validated method. Now, part of the studies did not show significant effects, and the panel thought that the dropout of study subjects was quite high in a number of studies, which makes the results more difficult to interpret. However, there was one well-designed study in quite a large number of children, and it did show a significant effect on rotavirus infection in these hospitalized children. However, unfortunately, the overall evidence did not convince the panel, and they concluded that it was not established that the consumption of LGG had an effect on development of gastrointestinal infections. The second case is that of the effect of Actimel, and the effect of Actimel on Clostridium difficile toxins in the gut, which reduces the incidence of acute diarrhea. And this was a true disease risk reduction claim, an Article 14 claim. The target population were adults over 50 years receiving antibiotic treatment. And there were 3 pivotal studies looking at the effect of Actimel on Clostridium difficile associated diarrhea. One was an observational study and another was a small pilot study, and the panel judged that no conclusions could be drawn from those studies. However, the third study was a well-designed and quite large study, and Actimel was effective in this study. However, the effect should have been shown on the toxins as a risk factor, and unfortunately there were no data on the effect of Actimel on the toxins in patients without diarrhea. So therefore, that was the criticism of the panel, that there were no data on fecal toxins in patients without the diarrhea. So therefore the conclusion was that the evidence for Actimel was insufficient to establish a cause and effect relationship. Please note that the judgment that evidence is insufficient is better than the judgment that that the relationship was not established. So there was quite good evidence, but still not enough. So if we look at EFSA's evaluation of health claims in general, we see that their criticism centers on the main issues that are listed on this slide. And with respect to ingredient characterization, it is important that you can show that the food constituent that was used in the studies you have submitted is the same food constituent that is the subject of the health claim. For example, if studies have been performed with single strains of probiotics and have demonstrated a beneficial effect, you cannot claim that effect for a multi-strain probiotic which combines these strains without any further evidence. Now, with respect to design and quality of studies, some improvement seems possible, and not per se from a scientific point of view, but to make sure all design issues are focused on the specific claim that you want to make. Now, if results are not statistically significant, small sample size may be an issue, but the main thing is, of course, the true efficacy of the product. If it is not that effective, you may not find a statistically significant result. Now, when the Nutrition and Health Claims Regulation came into force, there were no criteria for the scientific evidence, which means that the rejected dossiers were certainly not all based on inadequate science, but it means that the rules of the game were not clear. Now, on the basis of their own evaluations, the EFSA NDA panel for each health benefit area compiled a guidance document to explain the rules. And the first guidance document was for gut and immune function, and it addresses 2 key issues: which claimed effects are considered beneficial, and the other is which studies and which outcome measures are considered appropriate for substantiation. Now, in general, the regulation identifies 2 classes of beneficial physiological effects, and I've mentioned them before. It is the function claims, where a beneficial effect relates to maintenance or improvement of a function, and it's the reduction of disease risk claims. And then the claimed effect must relate not to reduction of the disease itself, but to reduction of a risk factor for the development of a disease. Now, keeping this in mind, we can understand why increasing bifidobacteria, for example, is not considered a health benefit in itself, because it doesn't represent a specific function. Now, what the panel did in case of claim applications that referred to the gut microbiota composition is that they acknowledged that preventing or reducing the numbers of pathogenic microorganisms could be considered an improved function, as well as reduction of a risk factor for disease. So they turned a lot of claims around. Instead of the positive effect on increasing bifidobacteria or lactobacilli, they focused on preventing or reducing the pathogens. Now, this slide summarizes the health benefits that EFSA has identified in the gut health domain. It's quite busy, but you may have a closer look at it afterwards. It also summarizes the outcome measures that may be applied in human studies to demonstrate an effect. The measures should, of course, be validated and also generally accepted. Now, defense against pathogens, over here, is considered a function claim, and infection episodes can be used as a marker of this function claim. In defense against pathogens, there's often also an immunological component. Therefore, maintaining a normal immune function is also considered a beneficial physiological effect, but it needs to be specified, for example, as immune defense against pathogens. If we focus again on defense against pathogens, we see that only a function claim can be based on measuring reduction in infections. Where's my pointer? Here. So reduction in gastrointestinal infections. It can support a function claim, but provided that it is also shown that we are really dealing with an infection. A disease risk reduction claim, on the other hand, cannot use incidence of infection as an outcome measure, because that would be considered a medical claim. But a disease risk reduction claim can only focus on reduction of the risk factor. And remember the claim for Actimel for reduction of Clostridium difficile toxins. Now, an immune defense claim has an additional criterion. You need to use similar outcomes as for defense against pathogens, but in addition, you need to show that relevant immunological parameters also change. Now, there are numerous pathogens, of course, that can cause gastrointestinal or respiratory infections, and which one you should focus on to demonstrate efficacy of your product really depends on its working mechanism. Different pathogens have different ways to induce symptoms, and also different functional ingredients have different ways to block these pathways. Now, EFSA in their guidance mentions a list of pathogens that they consider acceptable, and that also means that there is there are different pathogens that could be used in research models to substantiate a specific claim or mechanism. Now, in the next part of this webinar, my colleague Sandra ten Bruggekate will lead you through the different research models that are appropriate to demonstrate an effect on defense against pathogens. So now we will quickly change place, and we will be back with you in just a few seconds.
Well, that was rather quick, I think. Good morning and good afternoon. Thank you very much, Alwine, for your introduction to EFSA's guidance and learnings. The second part of our presentation will focus on which research tools can be used to substantiate health claims in the area of gut health and resistance to infections. But more specifically, I would like to focus on how to substantiate these claims in healthy subjects, which biomarkers to use, and which study setup can be used. Well, the proof of the pudding. How can we deliver the proof of the pudding, especially when validated biomarkers are lacking? Also, how can we deliver this proof in healthy subjects? Well, I think challenge studies are an attractive option. If we, for instance, take two subjects who look apparently healthy in this slide, which is depicted on the left, we will have great difficulty in distinguishing between these two subjects in nutritional intervention trials. This is because in the area of gut health and immunity, validated biomarkers are hard to find, and it is also difficult to obtain an effect size bigger than the normal healthy variation between subjects. However, if we administer a stressor, and that could be stressors like, for instance, an attenuated enterotoxic E. coli or a salmonella vaccine, or I'll name different ones in my presentation, if we give a stressor to the same individuals and bring these individuals outside the normal healthy variation, we will observe differences in adaptation to the stressor. You see the differences in subject 1 and subject 2. We might then be able to pick up a measurable effect of a nutritional intervention on the adaptation to this stressor. In the next slide, I will give an overview of examples of challenge studies. So different kinds of challenge studies can be distinguished, so strictly controlled challenge studies and natural infections in field trials. Strictly controlled challenge studies could be, for instance, common cold induction by a rhinovirus strain in healthy subjects, diarrhea induction by giving an oral antibiotic, infectious diarrhea induction by, for instance, an attenuated and enterotoxic E. coli strain, or salmonella vaccination in healthy subjects. Natural infection in field trials, which is a completely different ballgame, could be, for instance, infectious diarrhea in travelers, infectious diarrhea in high-risk population, and you could probably think of, for instance, infants at daycare being exposed to norovirus or rotavirus, or people in tropical countries that have spontaneous infections by, for instance, worm infections or all kinds of viruses and bacteria. Also you could think of natural occurring common cold, looking in the common cold season. So a controlled challenge versus a natural infection. Controlled challenges have a number of advantages compared to natural infections. For instance, you can control the type, the timing, and the dose of the pathogen inoculation. If you control the type, timing, and dose, you can also predict its time of system onset, and you would also know the timing and the time points which are relevant to measure different biomarkers in. You can closely monitor different clinical parameters. There is the possibility of taking more relevant biological samples, because you have strictly controlled and also subject visits with the healthy subjects. You have a lower noise to signal ratio, and all of these points will probably lead to lower subject numbers needed in a strictly controlled challenge compared to a natural infection. So I'll first start with a challenge with rhinovirus, which can induce common cold in healthy subjects. You can use a double-blind randomized placebo-controlled trial design with healthy subjects as a start out at baseline, and with different numbers per group depending on your effect size and depending on the subject variation. And you would probably, with functional ingredient screening, you would probably need around 40 to 60 people per group. After a dietary adaptation, and that the timing really depends on the functional ingredient you screen for, subjects are nasally infected with a rhinovirus, and this could be, for instance, well, different kinds of strains, HRV 16 or 39 are described in literature. And this rhinovirus is able to induce mild, short-lived symptoms, which you can pick up in a controlled design. Before and after challenge, you can collect different kinds of samples, fecal, nasal, and blood samples. And appropriate study outcomes in this design would be measuring viral particles in lung, for instance in sputum or in nasal lavage, which can be taken throughout different kinds of study visits. You can ask subjects to fill in common cold scores throughout the design, and you can look at the Wisconsin respiratory scores or rejection scores to validate or verify when common cold starts and how severe it is. You can look at spirometry, so looking at the volume and the flow of air that can be inhaled or exhaled. And you can screen for different kinds of inflammatory markers, for instance cytokine profile. So an interesting study which has been done, an elegant study by Malia et al. From 2011, we can see that the rhinovirus particles after nasal inoculation, which you can see on the y-axis, you can see that there is a 1 to 2 log difference in viral load between the controls, which is the gray line, and patients with chronic obstructive pulmonary disease, which is the black line. This is an elegant study because you can see that it drops down after 2 to 3 weeks, and viral particles can be detected up to 3 weeks after inoculation. Also, dietary interventions in these models are described in literature, and one very promising one was a study by Peterson et al. From 2009, which was a nutritional intervention study performed with conjugated linoleic acid, which is a fatty acid from dairy and meat products. And in this graph, to the left, you see that there's no differences in viral concentration. However, in the right graph, total symptom scores recorded by the subjects were lower on the CLA diet, indicated here by the gray line. Well, at NIZO, together with Nijmegen Medical Center in the Netherlands, we are also performing a rhinovirus challenge model, but we're still in the pilot study phase, which will be in 2013, and a little bit the analysis also in 2014. The pilot study has been performed with a total of 40 subjects per group, so a few healthy subjects and 10 per group, both male and female, because we want to see whether there is a gender difference, and also with, and that's an interesting one, with different kinds of serostatus, so negative and positive serostatus to the rhinovirus strain we administer. And we will screen for a large set of potential biomarkers. And coming up in 2014, 2015, we will do a nutritional intervention study, but this will include larger numbers of healthy subjects, so around 40 to 60 per group, but it's also dependent on the functional ingredient and the effect size we expect. So we will do ingredients testing, and we will only go for selected biomarkers, so biomarkers that have shown effects in the pilot study and which are relevant and can be measured at different time points will be selected in the nutritional intervention study. Then another challenge, a challenge with antibiotics. This is a design which is approximately a 4 to 6 weeks intervention. The time of intervention will probably depend on the functional ingredient, so adaptation to the diet, but also whether you want to see recovery from antibiotics, especially microbial recovery, which will take a few weeks maybe after taking the oral antibiotic. So again, healthy subjects, but you will need more subjects per group, so around 80 to 100, since our primary endpoint is antibiotic-associated diarrhea. Looking at diarrhea, we probably need around 80 to 100 subjects. Subjects can be treated with antibiotics. It could be different oral antibiotics, but for instance, amoxicillin for a duration of approximately 5 to 7 days. And outcomes studied can be duration, frequency and severity of bowel habit scores, looking for instance at the validated Bristol stool scale, the gastrointestinal symptom rating scale, looking at different kinds of adverse events, recording also adverse events, and microbial profiling and looking what the antibiotic and also the dietary treatment will do with the endogenous microbiota. Here you see an interesting study by Koning from 2008, and they found that a multi-species probiotic decreases antibiotic-associated diarrhea. If you look at this figure and looking at the sum score, you see that 79% of subjects in the placebo group had diarrhea, so antibiotic-associated diarrhea, indicated by a sum score of stool frequency and stool consistency, while only 48% of the subjects in the probiotic group experienced antibiotic-associated diarrhea. So this is an example of a dietary intervention in antibiotic-associated diarrhea, but then in a challenge design, so not looking at treatment of antibiotic-associated diarrhea, but looking at prevention also. Then a challenge with attenuated enterotoxic E. coli. So this is a parallel double-blind placebo-controlled study. Again, 4 to 6 weeks approximately duration of intervention, and the 4 to 6 weeks is dependent on the adaptation to the diet, whether you want to see complete recovery from the attenuated enterotoxic E. coli strain, and whether you want to look at recovery of microbial populations. Habitual diet, but subjects really have to abstain from foods high in calcium. And this is because we, in an earlier study in 2003, which was published in Gastroenterology, we saw that calcium protects against enterotoxic E. coli, and it really decreases enterotoxic E. coli survival, and it decreases infectious diarrhea. So healthy subjects, again, randomly assigned to experimental groups. Group sizes depend on functional ingredients and effect size, but should be around 20 to 30 per dietary group when you're focusing on the primary parameters. After adaptation to the diet, subjects are orally infected with an enterotoxic E. coli vaccine, and they receive 10 to the 9th or 10 to the 10th colony-forming units. The outcomes of interest are fecal enterotoxic E. coli excretion throughout time, so you will probably measure this until 10 days after oral inoculation. You can look at infection-induced diarrhea, at stool consistency, by the Bristol Stool Scale, for instance, the gastrointestinal symptom rating scale. Well, we started out doing this trial by first looking at whether a functional ingredient could protect against enterotoxic E. coli induced diarrhea, but also at enterotoxic E. coli persistence, so survival in the gastrointestinal tract. And what you can see here depicted in the left graph is fecal enterotoxic E. coli excretion. And what you would expect if enterotoxic E. coli as a pathogen can survive and grow in the gastrointestinal tract, you would expect high numbers throughout time because it grows and it will give high numbers in feces. So what we see in the control group, which is the top line, we see high numbers of enterotoxic E. coli, but it decreases within 8 to 14 days to detection level. When we look at the calcium supplemented group, and this is a calcium which will be in a normal Western diet, a calcium concentration, then we see a decrease in enterotoxic E. coli numbers throughout time, and this is almost 100 to 1,000-fold lower enterotoxic E. coli excretion. Also, when we look at the diarrhea which is induced by the enterotoxic E. coli, we see that calcium decreases infectious diarrhea throughout time. Well, we of course wanted to verify these results, which we obtained from animal studies in a human volunteer study. We did this study with 16 subjects per dietary group, and we supplemented people with either a normal calcium, so a normal milk with calcium in it, or they received a low calcium milk. And what you can see from day 0, where subjects were orally challenged with an enterotoxic E. coli strain, you see that infectious diarrhea, so the fecal output depicted on the y-axis, you see that it increases with 200 grams of wet weight per day. The second day after enterotoxic E. coli challenge, you see that the calcium group already goes back to normal fecal output, while the placebo group still has 100 to 150 grams of extra fecal output. You would probably think that this is a very minor effect because it's like only one day, but this attenuated enterotoxic E. coli strain only produces infectious diarrhea for 2 days. That's the maximum it can have. So you will see a decrease of 50%, so 1 day. Then another parameters you can look at is stool consistency, and we looked at this by the Bristol stool score, which subjects had to score online every day throughout the study. And we also looked at fecal calprotectin, which is an inflammatory marker which we measured before and after challenge. And what you really nicely see is, well, on day 0, people get an oral challenge with enterotoxic E. coli, and you very nicely see that the Bristol stool score goes up on day 1 and a little bit on day 2 after challenge, and then you see it going back to normal. When we're looking at fecal calprotectin, you see that it goes up on the 2nd and 3rd day after inoculation with enterotoxic E. coli. And we have different kinds of other markers, also inflammatory markers, and also looking at stool frequency, for instance, that show similar time curves. I forgot the arrow, sorry. Then a challenge with the salmonella vaccine. Again, a 4 to 6 weeks intervention. Dietary adaptation will also affect the time of intervention, and also the build-up of immunity, whether you want to determine this. Habitual diet, but abstain from foods high in functional ingredients, but that also applies to the different other designs. Healthy subjects, around 20 to 30 subjects are probably needed for a salmonella vaccine study. And after an adaptation period, subjects are orally vaccinated, and I gave here as an example Vivotif, which is a salmonella vaccine, which has to be given multiple times, so you can also see the titer after multiple times of giving the vaccination. Primary outcomes could be an increased number of individuals attaining protective levels, and an increased vaccination antibody titer. Well, until now, the presentation, I focused on strictly controlled challenge studies, and I'll now go into natural infections in field trials. I'll first focus on traveler's diarrhea. Well, again, a 4 to 6 weeks intervention, but this is a total different design. You will need healthy subjects, around 100 to 150 per group. So group sizes really increase in field trials. Subjects traveling to an area in the world with an increased risk of traveler's diarrhea, so any tropical country, are eligible. All subjects can keep symptoms and medication diaries and submit stool samples for pathogen carriage within 7 days of return. But please note that you can't or it's quite difficult to obtain stool samples throughout the holiday period. Outcome studied can be incidence of traveler's diarrhea, a proportion of subjects taking antibiotics throughout their holiday, for instance, the gastrointestinal symptom rating scales, which subjects should fill in throughout their holiday and the intervention, and looking at Bristol stool scale and stool frequency. But often there's no determination of bacterial or viral counts throughout the intervention because it's simply not possible. Then an example of a study by Verk et al. In 2013, looking at the effect of symbiotics, a combination of 2 probiotics and 1 prebiotic on traveler's diarrhea was determined. If you're looking at this first table, you can see that there's a trend towards less short duration diarrhea. However, no effect was seen on the total occurrence of diarrhea. In the second table, you see that constipation during intervention was decreased, but no differences in the use of antibiotics were observed. And I didn't show you this table, but they didn't show any effect on taking antibiotics throughout the intervention period. I see that there is a question in the audience.
Yes, Sandra, there is a question from one of the attendants, and it is, what are major considerations for defining the subject groups in both the randomized clinical trials and the field trials?
Depending group sizes really depends on the effect you expect. So the relevant effect you would expect after giving a functional ingredient. But not only the effect size you expect, but also the variation between subjects you expect in a trial. So you would do a proper power calculation before you would even start an intervention trial, either a challenge study or an intervention study in a field study. You would do a proper power calculation and then get the appropriate subject number. Does this answer your question, or? Okay, then infectious diarrhea in high-risk populations. This is a design in children in Indonesia which have spontaneous occurring diarrheal episodes, and also infectious diarrhea. In this design, we would need around 100 to 150 subjects per group, and subjects living permanently in low socioeconomic urban areas of Indonesia. A dietary intervention for 6 months, because you want to wait for spontaneous occurring infections. And study outcomes are the mean number of episodes and the duration of acute diarrheal disease, incidence and severity of acute diarrheal disease, intestinal colonization with pathogenic bacteria or viruses, and this could be the world, because bacteria and viruses, unlike a challenge study, you won't know which bacteria and viruses will infect the subject population. Incidence and mean episodes and duration of acute respiratory infections was taken as a secondary parameter. And here you see a nutritional intervention study published in 2012 in Pediatrics by Augustina et al. And in this nutritional intervention with regular milk, low calcium milk, and 2 probiotics, with a similar design as I indicated in the previous slide, it was observed that rhinovirus, and that's the red line in the graph, significantly decreased the incidence of all reported diarrhea. And all reported diarrhea was defined as more than 2 loose or liquid stools in 24 hours. Surprisingly, the regular calcium milk, as I explained a little bit earlier, we saw that calcium decreased the increased the resistance towards enterotoxic E. coli. And in this field study, calcium had no effect on the infectious diarrhea rate. So in this presentation, I focused on strictly controlled challenge studies and natural infection in field trials. For concluding remarks, my colleague Alwine Cardinaal will step in, and it will probably take, again, a few minutes. So I'll give the floor to Alwine.
Okay, thank you, Sandra, for this overview. Now, let me summarize some of the main issues we have discussed today. To substantiate a health claim in any area, but certainly also in the gut health and immunity domain, a dedicated research strategy will help you. Having the intended claim in mind will help you select the optimal design and the optimal outcome parameters. Whether the results will be positive and significant will then depend, of course, on the real efficacy of your product. Perhaps not many health claims have been approved so far, but the rules of the game have become clearer since the beginning. The methodology is there, and in particular, challenge studies form a powerful tool. So to select the right challenge, the preclinical pipeline offers a range of adequate models, and we haven't discussed those in detail, but they are available as well. So overall, we are convinced that yes, we can substantiate real health benefits for consumers. Now, with respect to the process of compiling a health claim dossier, we think it is worthwhile to critically review the available evidence for a particular health relationship. You may want to discard studies that are irrelevant to the specific claim, and you may also want to identify gaps in the data that perhaps warrant additional research. And sometimes the review of available data will lead to a different angle for your claim application. And lastly, I think as producers, and most of our attendees are producers, you know best that developing successful new products is a multidisciplinary process, and research on health benefits, especially aimed at obtaining health claims, should closely interact with knowledge on nutrition, on food technology, on processing, on sensory aspects, on consumer behavior, all of those. And a product with a health claim that is unpalatable, doesn't taste well, will not become a great success. So we are glad to have colleagues within NIZO that can cover these other aspects as well, together with our clients. And, well, thank you. I would like to end with saying thank you for staying with us till the end, and thank you for sending in a lot of questions. And if they haven't been answered yet during the webinar, we will reply as soon as possible after the webinar. And if you have any further questions, do not hesitate to contact Sandra or myself by email, and we will get back to you. And I get another message from my colleague is that we will leave the lines open for another 10 minutes to answer any more questions you may have. So once again, thank you for participating, and enjoy the rest of your day. Thank you.